Jacobs. I'm Dr. Stan Berman. Welcome to Mindful. Dan is an assistant professor in a department of school psychology, as a clinical psychologist who has had a variety of leadership roles in mental health and in psychology. I'm delighted to talk to you about one of your key areas of expertise today, which is about substance use and substance abuse in adolescence. And I look forward to our conversation.
Thanks for having me.
I'm delighted you're here. The media has gotten particularly active in describing substance abuse concerns in the last 3 or 4 years. And I know you and I have conversed about, is the incidence, frequency, epidemiology of substance abuse changed, or whether has the media been pulled to this issue more recently?
Yes and yes. So those of us who've been doing addiction and recovery work for a long time, we didn't just suddenly discover addiction. It's been around for a long time, and youth addiction's been around for a long time. What suddenly happened 3 to 4 years ago is more Caucasian rich people started overdosing from opioids. And all of a sudden that got people's attention. Those of us who've worked with people of lower SES levels, lower economic levels, different minority groups, well, there's been overdose rates in a number of towns around here for years, and they didn't get the same attention or press coverage. So that's a problem, and that's obviously linked to discrimination issues and lack of resources and things like that. In reality, though, there also has been an increase in abuse of opioids. Most people know about Oxycontin. So Oxycontin has only been on the scene since 97, I think, 96, 97. I was working in a hospital at the time. We started seeing the first cases of abuse back then. And really exploded into the early O's because there were a lot of folks who legitimately had back pain or knee pain or some kind of injury, and their doctors were swept up in prescribing these painkillers, and it was seen as a terrific thing. And no one really at the time explored how this was going to increase addictive nature, addictive problems. What a lot of folks back then had no concept of was that people who had no significant history of substance abuse prior to that could get hooked on painkillers, who would then slip over to heroin. Because if you're using 2 or 3 or 4 Oxycontin a day, and you've already used up your legal prescription, and you're now paying $80 to $100 a pill, and you're burning through $300 to $400 a day, which very quickly, if you're an adult, you burn through your own money, and if you're a kid, you're stealing money. Well, someone says heroin's $5 a bag. Why not try heroin? Except you can't function on heroin, and heroin will take anybody down. The other difference is that heroin 30 years ago was maybe 20% pure and cut with a bunch of baby laxatives and junk. These days, heroin could be as pure as 85 to 90%. So the heroin, because of manufacturing in Asia and in Mexico, and so the people who make drugs have gotten better at making better quality drugs with manufacturing techniques. So people underestimated the power of it. And a lot of communities, especially with kids, didn't want to address that there was a drug problem at all. So I've been in certain communities where a superintendent of schools or a mayor has publicly said, oh, we don't have drugs in our town, which has never really helped anybody. It's a little simplistic, or it's incredibly simplistic. The sudden brand new epidemic 3 years ago is not true at all. It's been around for a while. It's increased. I think demographics of who it's hit has changed.
Yes.
And I think that, and in fact, there have been some politicians who've been involved directly, or their family members, and I think that got some attention. So I'll take it, I'll take the attention. But the downside, and I've told you this before, is it's very reactive.
Yes.
The emphasis is still on reactive, what do we do now, not how do we prevent it, and not how do we avoid it.
Right.
And that's a problem, and that's why I'm interested in working with younger people, and not as much, I certainly work on the adult side of my private practice, but that's not my focus of most of the work that I'm doing now.
So let's talk about your work.
Sure.
You know that I share your strong conviction that efforts in primary and secondary prevention
Absolutely.
always make a great deal more sense than responding once a problem is fully grown to maturity. What are some of your approaches in primary and secondary prevention?
High schools, if they address this issue at all, are doing it maybe in a one-shot event or a big auditorium event or a commemorative event for someone, sadly, who has died in a car wreck around prom season. Usually that's alcohol related. Even, by the way, so when I was just talking about opioids, the number one drug abused by kids in this country is still alcohol. The number two drug is marijuana. pills become the third, depending on which pills you lump together. And most surveys, unfortunately, don't separate out painkillers from stimulants. The Youth Risk Behavior Survey, which is a terrific survey, they just say prescription medicine. So again, most of the education I see around these things, it's reactive. Something bad happened, now we'll address it. Or let's do a health education intervention, but it'll be a one-shot. And well, we know from all the research that that doesn't work. We know that frontal education's nice, it doesn't work. You need a mix of things. You need preferably to actually start working at the elementary level, if not the middle school level. Not necessarily let's walk into an elementary school and say, let's talk opioids, let's talk heroin, let's talk alcohol. No, not at all, but to talk about self-esteem, refusal skills, self-efficacy, coping, communication skills, school connectedness. I've been doing a lot of reading, a lot of work around the issue of school connectedness, which, by the way, is good for mental health issues too, not just substance abuse. Kids who report being more connected to academics, more connected to a teacher, more connected to a sense of community, are all less likely to engage in drug use, have depression, have anxiety, things like that. So you can be at an elementary or middle school, not say the word drugs at all, and still help decrease the risk of drugs. When I come into a place, if I get brought in as a consultant, and you know this too, you having done this for years too, the call is never, hey, everything's terrific, can you make us more terrific? The call is, something went wrong, we've got a problem, and maybe you've experienced this too. When I show up somewhere, I think to myself, I wish they called me 6 months ago. Because you can see the lines of things developing. It is better to work with a younger person who has not developed a hardcore problem than to work with an adult who has a hardcore problem. My cigarette example is usually the easiest one for people to understand. Show me an 18-year-old who started smoking cigarettes at 15, and show me a 38-year-old who started smoking cigarettes when she was 15. Who's easier to help? And it's not because of the physical addiction. We can detox anybody off of cigarettes, nicotine within 30 days max. And that's the hardest drug. Any other drug you can be detoxed within 4 to 5 days. You still feel rotten, but you don't need it to function. So, why aren't people doing it? Part of the problem is training. I think this past summer, we just had our inaugural run of a course in school psychology addressing substance abuse in schools. I think you were part of approving that. And, it was a brand new course I developed. The students I had in it were all either school psychologists getting their doctorates or soon-to-be school psychologists getting their master's CAGs. Every one of them in the room interested in the issue of substance abuse. One worked at an elementary, 2 or 3 worked in middle, the rest worked high school level. All of them were interested at different levels of how to do this. Well, 2 years ago, this course didn't exist. 10 minutes before I came in to see you, I just had a meeting for an hour with one of those students who was at the front end of her training in our doctoral track in school psychology. And we were talking about what can she do next, what independent study can she do down the road, how will she later do her doctoral project, what placements will she do. So I think that's going to be a shift. And I think the real shift is going to be for us to get students to then go and be professionals in the field with this interest. Psychologists traditionally, at least in this area, there aren't as many with this interest. I'm a member of the Society for Addiction Psychology through APA. That's great. Locally, there aren't as many folks interested in it, and in other fields too, by the way. We do have, Dr. Richard Riley in counseling teaches a wonderful course, and he's terrific. And the students in that program actually are required to take a 1-semester course as part of their licensure for LMHC. But nobody else in this building is required to do that because no other programs require it, because APA doesn't require it, NASP doesn't require it. And most of us traditionally learned it in the field.
I think communities felt very, very good when for a few decades they brought the DARE program into their communities. They felt we're doing something positively. We know the outcomes from DARE, unfortunately, were very, very disappointing.
Yes.
And so I'd like to hear your commentary on DARE and what shift in approach you have that makes you more confident about what you built and are delivering. And the second question is, having talked to us about those first 2 levels of education, talk to us a bit about what a system-wide intervention might look like in a secondary school.
Sure. If I was really going to do system-wide, by the way, I wouldn't just do it at the secondary level. System-wide is system-wide. So in fact, I actually have a model that I would put into place, but it's very hard to get people to buy into it. Coming from a cognitive behavioral background, I'm interested in what works and how do you measure it, and what's measurable and observable, and If the goal was to decrease substance use, DARE didn't work. It's interesting because literally 2 hours ago, working on this book project, I just started reading an article. It just came out this year. It's the new DARE. But it's not really DARE. It's about a program called Keeping It Real, which I've known about for a while, a bunch of us. And it's an interactive program, and they're trying to coin it, will it be the new DARE? And in fact, there will be no one program or no one manualized program. But the reason this program has a little advantage of it, it's interactive. There's a multimedia component. It's culturally sensitive. It was the original program I knew about was out of Phoenix, and they had a series of video vignettes, and they made sure, working for the kids who were of Latino origin, that the actors were of Latino origin. And they talked about cultural understanding. Now, it can go too much in the other direction. Let's only do this or this. This one, in fact, every kid can benefit from self-esteem. Every kid can benefit from communication. Every kid can benefit from refusal skills. The work I've done in my partial hospital programs and day programs, the thing we've definitely learned is that you talk to kids directly, and you're very honest about it, and you're very open about it. And suddenly, when it gets to this topic, or by the way, when I was trying to do the STD prevention and HIV prevention, people got very nervous. And surveys have been involved in. The comment is not, do we know what to do? The comment is, will I get fired for doing what you want me to do? So years ago it was, we're going to teach you to pass out condoms, and if kids were using intravenous drugs, intravenous needles to share drugs, we would teach them to clean the needles with bleach, right? Those were the two things we knew would decrease transmission of HIV. And school systems said, are you out of your mind? I'll get fired. So similar with substances, the myth was, if you talk to my kids about drugs, my kids will do drugs. When in fact, World Health Organization, everybody has said, no, that's not true. So I think when you talk to people and you say, well, at the elementary level, we're going to talk about substances, they think you are going to walk in and say, let's talk about shooting up heroin to a bunch of third graders, which of course is not the plan. But like I said, self-esteem, self-efficacy, refusal skills. Nobody has any qualms about saying stranger danger and self-protection and don't go with somebody you don't know. And yet, most of those cases, abuse doesn't come from strangers in white vans. They come from people within their family. And the bigger danger is, in fact, people with peer pressure and family disruption and family genetics and or environmental risks. There's a lot of risk out there. The good news is there's protective factors too. So I mentioned school connectedness. That's incredibly important. The neighbor lady who's the support system, that's incredibly important. Positive peers who aren't using. I'm a big fan of sports. This is a little risky because there are some sports teams, especially at the high school level, that glorify substance use. That's a mistake, obviously. And there's also coaches, by the way, and principals who ignore substance usage. So when I was on the North, working at Salem Hospital at the time, when the North Shore, we got hit by opioid abuse before a lot of other areas in Boston. And there was a famous case, and it was in the press, and the coach of the time, the young man who was in the paper who was supposed to go to the actually, he did. He went to the Florida Marlins, and this is all public knowledge. And the coach said, I didn't know. And every single kid on the team said, how did he not know? We all knew. And all the kids I was working with said, we get high with him at this place or this place. So it was very either disingenuous or clueless. Kids with substance issues don't respect anybody who's clueless. And kids without issues need somebody to be honest and direct with them. All right. In terms of how I would approach it with a system, you want it to be multi-tiered. You want the elementary to talk to the middle to talk to the high school. You want the different clinicians talking with the health educators. By the way, you don't have to create the wheel out of thin air. You can piggyback off of health education programs that already exist. You just don't want to do one-shots. All the studies say if you get 300 kids in an auditorium and you have a panel of people on the stage and you say drugs are bad, don't use drugs, there is no way that's going to work. Maybe you'll reach 2 kids, maybe you'll reach 50 kids. You're not going to reach all 300. I think maybe I've been a part of a couple of panels like that, and then I said I'll never do this again because it's not a good model. It doesn't work. Instead, get student leaders from the athletics teams, from the academic teams, from the student government. Train those kids to be peer leaders. I'm an enormous fan of peer leadership, judicial leadership programs. Train those kids in refusal skills, substance abuse risks, things like that. Then that is one component where you would have them work with a mix of different groups across cliques and cohorts, right? And you could have a community-wide organization, and you could have a poster campaign, and you could have a drama competition, and this makes sense. So you would, because there's no one thing that's going to reach every kid. By the way, you also have to take into account cultural diversity differences, kids from families where someone has a substance issue, kids from families who don't have a substance issue. How is that being interpreted, not interpreted? The one thing, when I'm talking to my students about this is they cannot go into the school and do this if the principal doesn't buy in. And the principal can't buy in if the superintendent doesn't buy in, and the superintendent won't buy in if the parents aren't supportive. So you have to have communication. Similar to a couple of years ago, there was all attention to bullying, anti-bullying, and statewide, and every school had to have a plan in place, and forgetting the years, maybe 4 or 5 years ago, but by December 31st, every school had to have a plan in place. And every school that whole fall was very active, very active, very active. And after January 1st, you didn't hear from anybody, which unfortunately meant a lot of schools were just getting paperwork in, and they weren't really changing their modality, they weren't really changing what was going to happen. That's frustrating. So I'm hoping that doesn't happen with this. So I will take the current media attention if it then gets us moving forward. Literally that is the project I'm working on right now. So I'm in the chapters on prevention and intervention. And at the end, the goal is to have a synthesis of the model I just started to talk about. Even if some schools it's prom season and the police will bring in a trashed car and they'll say this happened because of a drunk driver. It's kind of a fear appeal, and fear appeals don't work unless you give alternatives, right? And we've known that since 55, 56, something like that, but they still keep happening. But if you had to do that, well, okay, let's do a round robin around the gym, and let's have a letter writing campaign and one thing, and let's do an art project another. You could do it. You can piggyback off of things that already exist, but you have to make them work, and you have to have measurable feedback systems and evaluation systems.
So you've given an important sample of your work and how you think. People will sooner rather than later have a chance to read you and learn more. Yeah. And as we're wrapping up, a final reflection.
The reason I get frustrated for interventions that don't work, that no one's bothering to check, is because people die.
Yes.
So we just wrote in addition to the book I'm working on, our department, has been writing a book where we did different chapters, and I think I wrote one on aggression and violence, but the other chapter I wrote was, no shocker, on substance abuse. And in that chapter I did a number of case scenarios based on real cases I've worked with, and the one that is the most depressing case is the kid who overdosed and died. Because all the other cases, we can still help these kids. But when someone is dead, they are dead. And this is similar to depression and suicidality, which I think we have to take incredibly seriously, and I think does get a little more respect and attention to this topic. There's a lot of people with other mental health issues who are overwhelmed and they want to self-medicate with substances. And initially they do not have a substance use disorder, they are just self-medicating. Very quickly they can develop problems. And then your judgment is impaired, and then you're at high risk, and then people can die. And it doesn't have to happen. That's what's frustrating as a behaviorist to me. It's all preventable.
Yes.
Right? So health education models are lovely if people respond to it and work with it, with your background, of course. It is not that we have to invent fire. We just have to put the right information in the right hands, and there has to be political will to do it.
Yes.
Sometimes the attention goes in the wrong direction. So I wasn't going to mention, but Narcan. So Narcan is something that's very concerning to me right now, because a lot of places, it is, for people who don't know, when someone is overdosed on opioids, it's in the short term a terrific medicine. It tricks the brain into thinking the person should not die. They don't die. The EMTs get to them in the hospital. It can save lives. As a long-term solution, it's very controversial. And there's a number of people in public health who love it, and there's a number of people who think it's not great. And I'm one of them in the second group, especially for schools. So in recent years, a number of schools, if not all schools in Massachusetts, have been saying, let's make sure there's Narcan in every nurse's office. Except you can't find me the stat that says how many kids have overdosed on opioids on school grounds. So why do I think it's in place? Because it's easy to put it in place. Yes. You can get funding for it, you can put it in place. It then lets you off the hook. So the program I just talked to you about and what you just talked about, those are more complicated. I'm not claiming they're not. And they have a lot of moving parts. I'm not claiming they're not. But they work. Just putting Narcan in the nurse's office, if it then lets the school off the hook, in terms of developing a program, that's like saying, let's have some bullying legislation, but then we won't really do it, I don't have a lot of patience for that, because we can save kids and it's a problem.
So I want to thank you very much for a very lively conversation, and I think kids in the Commonwealth and kids in the United States are better off because you're an impatient man.
Thank you.